Good morning, everyone. How's it going? Everyone having a good morning so far? We're going to keep Dr. Staudt on a schedule because, as a neurosurgeon, he's balancing a couple of things right now, including patients getting ready for the operating room. For those of you I haven't met yet, I'm Brian. I'm one of the pediatric neurosurgeons here. I'm actually working on a bit of a career transition, so you're not going to be seeing my face around as much as I used to be here, but I'll still be working part-time. So you'll still see me, but just so you know who I am. This is Dr. Staudt. He's Mike. He's my good friend. He's from Canada. I wore a lot of plaid today, actually three different versions of plaid in his honor to do this morning. So just wanted to make sure that we all recognize the importance of plaid. So Dr. Staudt joined us in last year, almost a year now.
Yep.
Yeah.
Very first.
Yeah, very exciting. Very great to have him here. We go back to training. Actually, he was the Enfolded Fellow when I was the chief resident. Here at UH, and so it was really exciting to recruit him back. But just a little background. Every time you come to Grand Rounds, you're always kind of like, who's the person who's talking to me? Are they really qualified to be talking about whatever topic they are? Are they here because they're interviewing for a job? Are they here because the department said that they have to do something? So in the next 37 seconds, I'm going to declare to you that he is extremely qualified to talk to you about this topic in very few words or less. He is an MD, a Master of Science. He's a fellow of the RCSC.
Yeah, Royal College Physicians.
That's what I thought that was. The American Association of Neurological Surgeons and the Canadian Neurosurgery Foundation. No, what is that? What's that one?
That's Congress and
Oh, that's a CNS one? They do have a fellowship now, don't they? See, I don't know these things. He's an associate professor. He got his MD at, how do you, Schoolage?
University of Western Ontario.
University of Western Ontario. He did an enfolded fellowship here. He did a fellowship at the Albany Medical Center at Albany Medical College in New York. He worked in Michigan for 4 years, so he could still see Canada. And now he can still see Canada from Cleveland. He joined us in 2024. He has been the recipient of 25 honors and awards. He has given 52 talks, both internationally, regionally, locally, and including grand rounds, all invited presentations. He's published 71 peer review papers and published 15 book chapters, all in a 21-year career starting in medical school. So that's a heck of a lot in a really short amount of time. So Dr. Staudt's amazing. He's an epilepsy surgeon, a functional neurosurgeon. He's got interest in both, obviously, epilepsy treatment, functional neurosurgery. We've had a lot of conversations about how we might get more involved in pain management from a surgical perspective in pediatric care, something that he's super excited about as well. So we are very lucky to have him with us in general here at University Hospitals and in Cleveland, but also very lucky to have him here this morning. So Dr. Staudt.
Thank you very much, Brian, for a very generous introduction. Thank you for being present today. I'm going to talk about a topic that's a bit near and dear to my heart, and that's specifically neuromodulation. We'll kind of get into the specifics of that. This has the capacity for kind of transforming the way we treat epilepsy, and this is the paradigm shift that's been happening probably in the last 5 years, and certainly over the next 5 to 10 years, we'll see technologies to treat epilepsy kind of shift dramatically. So yeah, I was here many, many years ago. I was practicing in Michigan doing epilepsy surgery, and it's nice to come home in some way. These are my disclosures. None of them are relevant to the talk today. They are pretty much all to do with pain technologies. So as Brian was saying, there is interest in kind of establishing pediatric pain. That would be very wonderful. But today we're talking about seizures and epilepsy. And I stole this slide from my good friend, Andy Zilgett, who's my epileptologist in Michigan, kind of gives the breakdown of, well, what's a seizure and what's epilepsy. I'm not going to spend too much time on this, but there is a difference, which I'm sure everybody in this room does know. And the challenge comes in how do we treat focal versus generalized seizures in that bottom left corner there. If you have a focal seizure and you find an area of the brain that you can take out, you can destroy, you can disconnect, that's great. That can be most of the times, or maybe not most of the times, but a high percentage of times that can be a curative procedure. But unfortunately, it's not always that easy, that simple. You don't often have focal seizures, you have multifocal seizures, you have multilobar seizures, you have generalized seizures. That's where it becomes much more difficult and where neuromodulation has a greater kind of a role that could be played. Now, if you look in the bottom right, we talk about how do we treat epilepsy. Well, we have the micro and the macro mechanisms. So the micro are ASMs, or anti-seizure medications, and the macro are kind of what we're going to talk about today. So you can pretty much break it down into two different categories. So you have destructive, which is take out a lobe, temporal lobectomy. You can ablate it with laser. You can disconnect it. And we're going to focus today on the modulatory nature of it. So you can have open looped or closed loop. And I'll get into what those mean in a few minutes. And we have 3 different technologies. So What is neuromodulation? Very basically, it's in the name. So it's the modification or alteration of normal nervous system activity, and we can alter it via either electricity or drugs. So intrathecal drug delivery, baclofen, is neuromodulation. Traditionally, we think of obviously things like vagal nerve stimulators, deep brain stimulators, but neuromodulation has a wide kind of span even outside of that, outside of the implants. Think of TMS, think of direct cranial stimulation. All of those are neuromodulation, neuromodulatory modalities, and are probably used even more frequently these days than intracranial neuromodulation modalities. So there's a wide breadth, wide span of things that are neuromodulation. But why do we use it in epilepsy? Well, I'm sure you've seen these numbers before. So about a third of patients with epilepsy are drug resistant. The problem is that only a minority of those are actually candidates for any type of surgical resection. So that leaves us with a vast majority of patients who don't have a good option. Or let me rephrase that, they don't have a curative option. So a lot of times we think of epilepsy treatment in terms of palliation. And obviously palliation is not a bad word when it comes to treatment. We're trying to reduce seizure frequency, seizure severity, the burden of seizures. And often a palliative treatment can still be quite life-changing. So if you take a patient that's seizing dozens of times a day, hundreds of times a day, a couple of times a week, if you take that down 10, 50, 90%, it means something to every reduction means something different to each patient, to each caregiver. But palliation is not a dirty word when it comes to epilepsy treatments. So when you talk about neuromodulation, we're talking about three treatments. Vagal nerve stimulation, which is kind of the standard, the prototypical, responsive neurostimulation, and deep brain stimulation. We're going to go over all three. The reason why I'm presenting this to pediatric rounds, even though it's mostly in an adult context, is, like I said earlier, we're seeing the shift in terms of the way we think about epilepsy surgeries, mostly in kids, actually. So a lot of the stuff I'm going to talk about today is off-label in kids, and we'll get to that point too. But we're using a lot of these technologies in children of all age groups, from infants all the way up to 18. And again, that's where we're going to see the paradigm shift. So stimulation epilepsy is nothing new. We used to think that stimulating the cerebellum was the cure for epilepsy. Back in the 40s, we had experimental studies. Back in the 70s and 80s, we had some human studies. Never really worked out. Interestingly, cerebellar stimulation is used these days for stroke rehabilitation because obviously the cerebellum has rich interconnectivity with pretty much everything in the brain, especially the thalamus. But when we talk about where we think about treating epilepsy, that's where it becomes a bit more difficult. So if you're trying to treat a generalized epilepsy, well, where in the brain do you actually stimulate? So these are kind of the targets that have been discussed. So on the left there, you have the central median nucleus, the hippocampus, obviously. On the right, the anterior thalamic nucleus, subthalamic nucleus even, and the cerebellum. So those are kind of the targets that have been mostly investigated experimentally. And then you get into the picture that makes everybody's eyes go cross-eyed. So the neurocircuitry. Don't spend too much time kind of trying to dissect this out. The point being is that in the red, the circuit of Papes or Papez, however you want to say it, that's kind of the real driver of a lot of epilepsies, especially frontotemporal epilepsies. And so there's a lot of interconnectivity here. You'll see that kind of runs through the thalamus, and that's in the middle right there. So Papes is important, cerebellar circuit's important, basal ganglia is important. But again, where are we targeting in here to treat a generalized versus a focal versus a multifocal epilepsy? That's been on everybody's mind. So we briefly talked about the techniques, the intracranial and extracranial techniques. That's kind of a recapitulation of this. More important is the concept of closing the loop. When we talk about open loop or closed loop, an open loop is basically you as the provider are setting the pace. So you have a deep brain stimulator for someone that has tremor. Basically, you turn it up until the tremor goes away. You turn it up too high, you get side effects. You turn it back down so you kind of meet that kind of sweet spot in the middle. That's an open loop technology where you yourself are changing the field, the strength of stimulation to affect a neurological change. Closed loop is different. So closed loop means that the device itself is reading an electrographic biomarker and responding to that biomarker. So in epilepsy, a biomarker can be a seizure or electrographic change. And so we'll get into this with responsive neurostimulation, but the devices can actually, again, read an impending seizure and deliver a bolt of electricity to try to abort that seizure. That's the whole idea with closed loop. And so we're trying to apply this to many different neurological disorders. Again, Parkinson's is the big one. We want to find a marker for tremor. If you ever heard of beta bands, that's kind of the big push these days. So some of the DBS systems can read local field potentials. We're not at the point that we're actually responding to them, but that's the next step in this. So epilepsy is actually ahead of the curve when it comes to closed loop technologies. And closed loop still needs your input as the provider. What I mean by that is basically when you implant a system that has closed loop, it's going to give you a readout over time. And you're going to look at that readout and decide what is a clinical event. And you're going to adjust things like a detection threshold, how much energy is delivered. So it's not perfect. That might be AI in the future as we throw that word out a lot, but still, that's the way closed loop works currently. So if we look at those devices, they've been in use for many, many years at this point. So for FDA approval, VNS was approved back in 97, RNS 2014, and DBS in 2018. Interestingly, DBS was approved last. But in children, we only have VNS. And in children, we only have VNS to the age of 4. And obviously, we do implant children with younger than 4 with VNS, not commonly, but it does happen. In fact, VNS implants overall have gone down over the years. We don't implant many anymore. I'm not sure if they've implanted one here new for quite some time. And even when I was in Michigan, I probably did maybe 20 over 3 to 4 years. And then unfortunately, we don't have any approval yet for RNS or DBS, and these things are forthcoming. So everything we talk about, everything we're using in terms of intracranial stimulation is off label for pediatrics. So we'll go over each technology kind of beat by beat. Vagal nerve stimulation being the one people probably know the most. There was experimental evidence even back in the 1880s about VNS stimulation in patients with seizures. Then it transitioned to animal models. The first report of an actual VNS treatment was in 1987 in dogs. And then a year later, the first implant was done in humans. Interestingly enough, that patient actually became seizure-free. And we never say that VNS leads to seizure freedom. And so from there led to the pivotal trials. The first RCT was in 92. Over the 90s, you had multi-center throughout Europe and North America. And then the approval came in 1997. And remember, pediatrics didn't come until 2017. So the mechanism is unknown. And this is the amazing thing about the vagus nerve, because again, it has such rich interconnectivity. What's it actually doing? That's a great question. So VNS is not a constant stimulation. It's an intermittent stimulation. And that's one of the difficult things for patients too, is if you stimulate too much, you get that kind of hoarseness, you get that pulling sensation. Then you have to bring the stimulation down, again, trying to find that risk benefit of too much stimulation versus trying to get some sort of seizure reduction. But the idea with the stimulation is that hypothetically, theoretically, it's going to the solitary tract nucleus, projections to the locus ceruleus, and then the anti-seizure effect is hypothesized due to some sort of noradrenergic modulation. So this is a very, very imperfect description. Because VNS is also used for stroke rehabilitation. It's used for depression. Those are the two devices that are kind of gaining popularity. It's used for refractory hypertension. It's a fourth-line hypertension treatment, believe it or not. It's used for rheumatoid arthritis. It's used for irritable bowel disease. So it's used for many different things. You'll notice that a lot of them have a theme of inflammation, maybe. So that's kind of the underlying principle. But again, no one exactly knows how it works. But it does work. It doesn't work amazingly, but it does work. VNS surgery is very standard, but it's very annoying too. I always tell patients, like, I hate implanting these, but implanting a DBS or an RNS is actually very, very straightforward. The reason being is getting it around the nerve is very painful. But the exposure is very kind of straightforward for us as neurosurgeons. It's on the way to do an anterior cervical discectomy. We just go over the side a little bit. It's right between the carotid and the jugular. So it's an area that we're very familiar with. It's a very thick nerve, so it's almost hard to miss. The challenge here in terms of the implantation is this. It's actually, these things are coils. You have to unfurl the coils, and you have this tiny little piece of spaghetti nerve that you're trying to put the coils around. And so sometimes you get it just right that first time and it feels great, or you're struggling for like 30, 40 minutes trying to get those coils on, because you put one on, other one pops off. So it's an annoying surgery. And I always say the worst surgery in neurosurgery is trying to remove one of these. So actually the company has, over time, let me step back for a second. Most devices, if they are cut or a lead is abandoned, they can never have an MRI again for a variety of reasons. For impedance, you can burn tissues. This is one of the only devices that you can actually cut in the body and have an MRI, because they've done the studies, because people do not remove these. You have to go down to pretty much the termination of the electrodes and cut about 2 centimeters below that, and they're MRI compatible. I have removed these. It's taken hours before. Sometimes you need ENT. You're under a microscope. I've gotten holes in the carotid artery. It's not a fun surgery to do, but sometimes it does need to be done. There's a lot of evidence supporting VNS. The evidence for seizure reduction, it's not great evidence. If you've heard the numbers, typically we kind of say that 30% of patients might have 50% seizure reduction of 30-50. We say that quite often. In the trials, you can even see like these are not great endpoints for the primary and the secondary. You're getting around hovering around 20-30% for seizure reduction and 50% responder rate. The interesting thing about VNS, much like all these modalities, is that they get better over time. And again, it's interesting kind of neuroplasticity that we don't yet understand. Why do these therapies get better over time? They do, though. And so there's some sort of brain rewiring that happens. VNS was the first kind of prototypical indication of that, but we see with DBS and RNS as well. So the responder probability or 50% seizure reduction is just under 50%. Again, in the past, when people didn't have other options, that's an amazing number. And even currently today, especially like all these things I'm going to talk about intracranially, like these aren't available in third world countries. So like what is available? VNS is available. It's expensive, but it is available. So this is still an option. It's still a good option, but you look at these numbers like, well, that's not a great number. But think about it again in someone who has no other option. So you'll see VNS in a lot of patients that are, for a variety of different reasons. LivaNova, who's the company that makes this, their biggest business is the battery replacements because they typically have to be replaced if they're on a high charge burn almost every 2 years. So imagine someone coming in having had a device put in their childhood, and almost every 2 or 3 years has to have a battery replacement. And then if that battery gets infected, oh my goodness, don't even think about that. So this is a bit of an older meta-analysis, but probably one of the better ones done. Looked at about 3,000 patients. Overall seizure reduction is about 45%. And again, it gets better over time. First 3 to 12 months, it's hovering around 30-40, it gets up from there. And so typically you plateau around 2 years. So that's where you reach your maximum seizure reduction threshold. The highest responder rates we see, pediatrics, generalized, post-traumatic, and tuberous sclerosis. And these are the most difficult to treat. So these are typically not the focal ones. These are the more generalized, the more multifocal, the more multi-lobar. So the studies have shown that the best responders are in general pediatrics. I did talk about what's a closed loop. Vagal nerve stimulation is something that you turn on, you turn up, you turn down. This is closed loop kind of in spirit only. The reason being is there's a very defined biomarker in epilepsy called ictal tachycardia, meaning your heart rate raises right before you have a seizure or during a seizure. And so these devices actually have incorporated a tachycardia-based seizure detection. So if you have a spike in your heart rate, it'll actually discharge. And so that's kind of closed loop. It's not really, but it's in the area that you didn't program this. It's doing it on its own. You gave the detection threshold, but it is doing it on its own. And obviously with the magnets, you can also discharge it yourself, or your caregiver can do that too. So if we move on to deep brain stimulation, so that's the only extracranial stimulation is vagal nerve stimulation. And there's actually external devices too. We don't use those for epilepsy. Some people use them for some pain syndromes, for headaches, migraines, things like that. But the only epilepsy indication is like the actual implant for VNS, not the extracranial one, or not the external one. So deep brain stimulation, obviously being most well-known, most popular for things like essential tremor, Parkinson's, dystonia. It has a very real role in the treatments of epilepsy too. So the prototypical target here is the anterior thalamic nucleus. And why is that? It's because it's the primary relay of the circuit of Papes, that very convoluted figure I showed you earlier. And so the idea being that most seizures being frontotemporal in nature are limbic seizures. So they go through hippocampus, they go through the fornix, mammillary bodies, anterior thalamic nucleus. It's a whole circuit. So the idea being that you disrupt this limbic circuitry. And so there were many different targets that were investigated. This was kind of the big one that came up, or the most consistent one that came up. And you can see at that last little paragraph there, you have afferent input from the hippocampal subiculum, goes through the fornix, the mammothalamic tract, and that's reciprocal connections to the frontal and the cingulate. So these are when you do invasive studies in epilepsy, you can actually watch seizures propagate, and you can watch it propagate along that tract. We actually don't often have something in the thalamus, but you have something in the cingulate, in the hippocampus, in the frontal lobe, and you'll see that kind of track along the after discharges. When it comes to actually doing this surgically, the targeting, it's somewhat difficult because in the brain, you're like, well, where the heck is the anterior thalamic nucleus? I assume most people know where the thalamus is. being right here. And the anterior thalamic nucleus is probably in the anterior portion. But the actual target, if you can see it, is this little guy. So you see those two little dark dots? That's the mammillothalamic tract. And you can't see that on a normal MRI. You can't see that on a flare. You can't see that on a T2. Does anybody know what this sequence is? Anybody? F gator. And so it's a very specific white matter attenuation where it really brings out that specific mammillothalamic tract. And one of the challenges too is when you're trying to target it in people who are patients that don't have normal anatomy, often kids with epilepsy, you might not see that, or you might see a distorted mammillothalamic tract. So that being your target can sometimes make things very difficult. Here it's very nice, but it's not always so nice. The other challenge when you're doing targeting in the brain is when you put a deep brain stimulator electrode in, or any electrode really, the point is you're trying to avoid things like blood vessels, you're trying to avoid sulci, trying to avoid the ventricle, because you want the straightest path to your targets, and you don't want to be impeded by anything. You don't want to cause a stroke. You don't want to cause a bleed. This has like all of those challenges rolled into one. That surgical window right there is very small. Because this is a transventricular approach. As you can imagine, the anterior nucleus, like literally hugging the medial wall right there of your third ventricle, is right underneath your thalamostriate veins. And so you have to actually pierce between your thalamostriate veins to get right to it through the ventricle. And so I think the first couple times I actually did this, I was a little bit hesitant, and you get over it. You realize that if you kind of twist the electrode, it actually kind of pushes things away. But I've put electrodes in here with like clearance of 1 millimeter. Which can be a little bit scary. And to be fair, I've never had a bleed, and actually the major trial of this also did not have bleeds. So by kind of, again, being gentle, being careful, pushing the lead in, even though you have this very, very small space, you can still get in there pretty safely. And it's pretty important to get to that space too. And I'll tell you that in a second. This also kind of kicked off what we could now call like a sleep DBS. I think everybody thinks about deep brain stimulation as patients awake, you're doing all the tremor testing. Once you're in the area and you're confirmed electrophysiologically, you confirm it, we're shutting off the tremor, then you put the patient to sleep and you put the electrodes in. Here at UH, we don't do any of that for any of our tremor patients anymore. We actually put them to sleep for everything. This actually kicked it off in a way because there's no electrophysiological testing for epilepsy. There's no biomarker to test. When we do the microelectrode recording, which is listening to local field potentials as we go in, there's no electrophysiological marker to listen to. So people just put these leads in and close up basically. So don't need any patient participation. So that's great because not all epilepsy patients, many of them have developmental delay, especially kids have difficulties being awake for a long surgery like this. So it's a very kind of nice setup that's changed the way we think about doing deep brain stimulation in general. So what we do, and this is what we do for adults for everything now, is we put the patient to sleep. We use this thing called the O-arm, which is a radial X-ray, like an intraoperative CT scan. We use that to get our markers. We put the electrodes in. We get another O-arm spin to confirm our placements, and you're done. Bob's your uncle. So it's streamlined things remarkably for pretty much every facet of deep brain stimulation. This was the big study that was done, published in 2010. The basic point being is that there was a significant seizure reduction that was most significant in post-hoc analysis for temporal lobe seizures. So like I said, limbic epilepsy, frontal temporal nature, that's where deep brain stimulation is the best, has the best evidence. And if you're paying attention, you'll see that you'll remember back in the original slide that this was approved in 2018. So if the study was published in 2010 and it was 2018, what took almost a decade to get it approved, there was one patient in this study that had a paradoxical increase in their seizures, like crazy. And so the FDA actually shut everything down and made them repeat parts of the study and followed that patient for 6 years until they actually approved it. So good on the FDA for doing that. And so this is the evidence with the open label extension. That's the OLE. And so obviously with randomized control trials, that forms the basis of FDA approval. Level 1 evidence, we see about a 40% reduction. And then again, that's kind of in the initial period. And remember that these things get better over time. And so we see actually a pretty significant improvement, seizure reduction, mostly again for temporal seizures. So if you take everything together, it's about 75% reduction for someone who has temporal epilepsy. So if someone has bitemporal epilepsy, this was the treatment until RNS came around. But you'll still see some centers. Actually, Emory does a lot of this, and they're a big neuromodulation center. They'll do a lot of deep brain stimulation for epilepsy. So for pediatrics, this is an older systematic review at this point. The point of why I included it, it's more so to show that there's a lot of different targeting that's going on. So even though the ANT is the only actual indication on label target, as I showed you at a very early slide, there's so many different areas that people have tried and are still trying. So DBS in peds, I would say, is it's a bit plateaued. RNS for peds has gone out the window, but this hasn't grown too much in recent years. But you can see here, people have tried thalamus, central median thalamus, hippocampal, subthalamic, a lot of different targets. And overall, in pediatrics, you're seeing excellent numbers, pretty similar to the seizure-free it's pretty dissimilar to VNS, because seizure freedom in VNS we don't talk about. It's like 1%. Here it's about 10-ish%, and you're seeing up to about 70, 80, 85% seizure reduction. And again, that's a very heterogeneous cohort. Again, these are case studies. These are retrospective reviews. Some of these might have 30, 40, 50 patients, but these are not randomized control trials. So always take those numbers with a grain of salt. And then kind of getting back to that earlier point I wanted to make about, well, what might influence placements or efficacy of deep brain stimulation. So with the anterior thalamic nucleus, it's such a small area that you really have to take a very specific approach through the ventricle. So on the left side there, you'll see one study that went transventricular, which is kind of the normal way to do it. And the other one went extraventricular, and you'll see that they missed it. So there's a little bit of wiggle room you can do with directional stimulation. It doesn't work great for this, especially if you're completely outside the target. So some people have actually described going like actual lateral placement, like an occipital longitudinal placement. The point being is that you got to get to that target. And this was my very first patient that I did, which was a pediatric patient back in Michigan. And some of the challenges with targeting and surgical planning is obviously this patient had a previous corpus callosotomy. So how do you get around that? So there's a surgical scar, there's plates there, there's the surgical defect. So that's a very atypical kind of placement for leads. For like tremor, it's like this. They're nice and symmetrical as most of the time. And these are almost midline. So that yellow one is like less than a centimeter from a superior sagittal sinus. So a little bit of kind of swallowing your pride as you're putting these in or planning for this, and just kind of taking the jump. But then you'll see it's transventricular on both sides, and you can see those black little squiggly lines. Those are the mammothalamic tracts, and that's exactly where you want to be. And so this patient, as I'll get to later in the talk, also had a VNS. And so synergistic, so this patient had a corpus callosotomy, a VNS, and a DBS. And that's another kind of leap in logic that we're trying to make in terms of figuring out how to use technologies more. So now we get to the last technology, that being responsive neurostimulation. So responsive neurostimulation is the newest of all of these. It is the most exciting. If you remember from the earlier slides, this is what we call closed loop stimulation. So it can read signals in the brain and then respond appropriately. Obviously, we still program it to the threshold which it needs to respond. So the way that it works, so on label, it's for partial epilepsy. So if you have, you can treat up to 2 seizure foci. The way it works is you have electrical disruption of synchronous activity. So basically, when you have that kind of lead up to a seizure, it will read that, it'll blast with electricity, and it'll dissipate. And the way that some people think it works is through membrane hyperpolarization. And much like all these technologies, no one knows exactly how it works, but we have general ideas. So for a typical case where you're trying to plan a neurostimulation, a responsive neurostimulation, again, on label, it's for people who have epilepsy coming from two different areas, basically. So this is the first RNS patient I did, again, back in Michigan. This is a patient with bitemporal epilepsy, fairly extensive SEEG or depth electrode invasive study. I think we did 24 electrodes in him. So pretty broad coverage of the temporal lobe, some frontal lobe, cingulates. Those ones coming in through the top are going to the insula. So this helps us define a couple things. Whenever we do an SEEG study, for adults or pediatrics. The whole point is that you don't go on a fishing expedition. You want to have a hypothesis. So that can take years sometimes to build up to. So if a patient has generalized epilepsy, generalized by their semiology, generalized by their scalp EEG, you're often not going to do this. You almost never do any sort of invasive study because there's nothing that's going to lead you to a hypothesis that you're going to take a piece of brain in a patient with a generalized epilepsy. That's why you never see generalized patients go to SEEG. But for patients that have bitemporal, you want to make sure it's bitemporal. Sometimes sometimes one temporal lobe can have a much higher predisposition to seize than the other temporal lobe. And we talk about palliative treatments. If one temporal lobe is seizing 80% of the time, you can take that temporal lobe out and still give patients a significant seizure reduction. So this patient had bitemporal epilepsy, was seizing hundreds of times per day. And in this gentleman's case, like he wasn't actually aware of it all the time. He thought he was having hypoglycemic episodes. So he thought he was diabetic and kept going back to his PCP. But that was his aura, actually, was the feeling of kind of like your stomach dropping and the hypoglycemic, like kind of getting lightheaded. And so we did that through the SEEG, and both sides were quite active. So we decided to proceed with RNS for him. So RNS goes right in the skull, as opposed to the DBS, which goes in the chest, and the leads go here, and the VNS, obviously, which is all right here. Here, the leads go into the brain, and the battery goes into the skull. So it can be a little bit disconcerting for some patients, being like, yes, I'm taking out a chunk of your skull like this. 95% of patients want me to keep it for them, and I don't know where they put it. They might put it in their freezer, like a serial killer, but some people do some weird things. But that's what it looks like. So you cut out a chunk of their skull. This thing actually fits right in that defect, and it fits quite well too. It doesn't stick up. And so that brings in the interesting point too, is we're talking about all these technologies. What about pediatric skulls? Do you do these in kids that are 8, 4, 18? Like kids grow. And so you have to take that in consideration. So the youngest reported RNS, I believe, is 3 years old. The youngest I've done is 10. So typically you want to wait for around the age of 8 for the skull to have matured appropriately. But sometimes you can be a bit creative with your indications. The other thing too is you're anchoring these leads on the exterior of the skull. So over time, depending on how young they are, they can like pull out. So you always have to kind of you have to keep an eye on patients with successive scans over time, especially if the efficacy drops. You want to make sure that they're still in the same place. So there's a lot of considerations for pediatrics, and again, because it's all off-label, there's no actual like guidebook, playbook to define who's a good candidate or how we should be implanting these in kids, because we're just so used to doing it in adults. But this is what it looks like in an adult once it's put in. That was this patient. So you see the 2 hippocampal leads kind of coming from the back. And that last one's actually an insular lead. And so this only hooks up to 2 electrodes, sorry. But future generation devices will have 4. That's a long ways away. But the whole point why I do another electrode is if there are other areas that are active and you feel that you might switch it up sometime in the future, you can already have the electrode there and you just have to hook it up. You just swap them out as opposed to redoing the operation. And after a year, we actually found out that, again, most of his seizures came from one side. So I actually did a left temporal lobectomy and then hooked up the other 2. And so he has therapy on he has the therapy on one side and the temporal lobe out on that side. And he is, I think he's 80 to 90% seizure reduction. So that's a very good result for him. And it's not just depth leads, you can actually have little strips too. So for people that might have like an eloquent cortex, like a perirolandic epilepsy, you can actually put like a little strip, like a grid over top of that area. And this is what it looks like when you're doing the recordings. These are hippocampal leads. I think these are actually, this is that patient too. So just for example, on that top screen, you can see where it says R hip, so right hippocampus, left hippocampus. The right one is fairly quiescent at that point, and the left one's starting to lead up to a seizure. So this is like detection. So this is where you're training the device. You're trying to figure out what's the electrographic signature that you need to pick threshold where you're starting stimulation. So he's having a seizure right now from his left hippocampus at that point, and that's what that detection is showing. So good evidence for this as well. Obviously, had to be done through an RCT. This is always very interesting to me. So you see on the graph over on the right through a pivotal study, yeah, you see the sham group actually had a seizure reduction when we put the leads in. And so we talk about lesional effects, microlesional effects when we do implants. So in tremor for patients with Parkinson's or essential tremor, you put the leads in, the patients actually kind of lose their tremor, or just have a significant reduction that comes back over time. We see the same in epilepsy. It's hard to say it's a microlesional effect because you're only getting like one part of the network, but it's interesting. So in this pivotal study, you had a significant reduction in seizures in the sham group. And then you see that on the right where it just spikes up. That's when when the brain figured out that the placebo effect went away. It's amazing. And then they turn it on and you had a reduction again. So if you ever want a really good example of a placebo sham effect, it's right there. That big spike towards the end of the blinded randomization period. So we look at the evidence again. We look at the open label extensions, and again we're seeing seizure reductions improve over time. So you see that initial kind of 30, 40, 50% reduction, and then that gets up to about 70, 80%, which is the same as about DBS. And remember that VNS stopped around 40, 50%. And this is another one where we're talking about seizure freedom. So often we don't talk about seizure freedom in patients with epilepsy. And this is for patients with focal epilepsy, mostly bitemporal, 20% seizure freedom, which is a very good number for patients that traditionally would not have any other option or might just be a VNS candidate. So this is the one field where we've seen an explosion in research for pediatrics. You'll see many big centers doing this now. You go to if you go to talks, so I was just at American Epilepsy AES back in December, and there's a lot of focus on this in pediatrics. And so traditionally we talk about big disconnected procedures in peds, because not a lot of peds are candidates for focal resections. So corpus callosotomy, hemispherotomies, things like that. And they're either using RNS as an adjunct to patients who've already had that, or they're using it de novo, especially for patients with like Lennox-Gastaut or other generalized epilepsies. And they're having pretty remarkable responses. And such though, that's you talk to big epilepsy surgeons like Taylor Abel at UPMC or Arya Fala in California, and they're like, this is the focus now where pediatric epilepsy surgery is going. So here is just a kind of a snapshot. This is a paper that was published in 2023 of some of the bigger case series. And again, always in the back of your mind, you have to take this with a grain of salt. Case series, retrospective studies are not level one evidence. They can maybe inform design of a trial, give you an idea of where things are headed, but still not level one evidence to hang your hat on, and certainly not for an FDA approval. So probably the biggest case series up there is the first one with 56 patients. But we're seeing big series now of 30, 40, 50 patients. We're seeing multi-center series. And it's not just one indication, it's heterogeneous indications, but a big thing is the generalized epilepsies. And patients are doing pretty remarkably well with these therapies. So much so that thankfully, we're now moving on to clinical trials. The company that makes RNS is called NeuroPace. It's only one company. And they're doing two studies specifically for pediatrics. Unfortunately or fortunately, that's defined as 12 years of age or older. So we will not have anything under 12, but you got to start somewhere. And I'm sure they did this because of again, I was talking to the issues about the healing, the tissue, the skull. That's probably the main reason they wanted to have a pretty stable age where you're not going to have much growth after that in terms of skull growth. So they're looking at specifically LGS, which is a big one, obviously. And then they're looking at the response study, which is again kind of analogous to the initial adult study with focal epilepsies. And then kind of the last points I want to make around this have to do with generalized discharges. So I've mentioned a lot to you about generalized epilepsy, LGS, IG, which is idiopathic generalized epilepsy. These are remarkably difficult to treat because you don't know where to target. So these patients are not candidate for focal disconnections. Focal resections. So what do you do here? Well, people have been doing corpus callosotomies. Do you do a full corpus callosotomy? Do you do an anterior two-thirds, posterior two-thirds, vagal nerve stimulators, things like that, big multi-lobar disconnections for truly intractable epilepsies. The whole kind of hypothesis, though, is that the relay for generalized discharges is thalamic in nature, because everything has to run through the thalamus. Everything already runs through the thalamus, but specifically seizures that run through the thalamus. And you have activation of specific structures that originate or that project to the thalamus. So the central median nucleus is kind of the big player right now. You'll hear a lot of this if you're familiar with the field with any type of intracranial stimulation. Central median, central median, central median. There are so many reciprocal connections. So it's a diffuse projecting, not a relay. And it has roles in sensory motor function, nociception, attention arousal, massive connectivity to the basal ganglia. And then there's also suggestion that there's connections with the anterior insula and frontal operculum. So huge, huge connectivity with the central median nucleus. And so the big focus has been on specifically idiopathic generalized epilepsy. That's a very specific type of generalized epilepsy. These patients are developmentally normal and have very frequent generalized tonic-clonic seizures. And so this, I think the first study, this is not the first study, but it's one of the initial ones. And these are case reports. And so that's one of my case reports that we had in Michigan. But this has kind of built up to a critical mass at this point that the company, again, has designed this study. And you might have heard of this. It's called Nautilus. It's actually finished enrollment, and they're finishing data collection. I think will be done this year, and it should be published for the next 2 years. And we're seeing pretty remarkable results. So we're seeing people cured of generalized tonic-clonic seizures with generalized epilepsy, which would never even be in the conversation 5-10 years ago. And we're seeing a significant reduction of other seizures. So you're kind of giving these people their life back, whereas previously they had nothing. And VNS was not a great option for these patients. So I talked to you about low levels of evidence, but everything has to start somewhere. And yeah, this is all off label. So every time we do it, it can be challenging. We probably did about 20 cases in Michigan, which is a pretty high number. And there's probably been almost 100 done in the country. So it's got, like I said, it has critical mass right now. And the study it's no longer recruiting, and hopefully will be completed in the next couple of years. And yeah, so I talk a lot about ANT, CMT. They're very close, but they're very far apart. Some people have looked at targeting both simultaneously. And the question is too, do you target one or the other? And that it has yet to be seen. And in the pediatric world, this is a study that came out of the clinic, I think last year, looking at individual patient data and seeing that, again, you're seeing a pretty significant seizure reduction with those responders are over 50%, also pretty significant in that middle column, and even patients over 75%. That's a very good number. And these are not numbers we've seen previously with any other sort of neuromodulation. And again, these are patients primarily with generalized epilepsy. So these patients are doing quite well. So the real interesting thing, which is really kind of nascent right now, is combining neuromodulation modalities. So I showed you that initial patient that I did that had a corpus callosum, that had a VNS, and then I put in a DBS. I've probably done 5 or 6 DBS with VNS, and you're starting to see these case series kind of pop up. This is Carrie Mew in New York, who's big into neuromod for pediatrics specifically. So that's the one pediatric paper. But you're seeing a combination. It's not just VNS DBS, it's VNS RNS, it's RNS DBS. I put in 2 RNS devices before. So really the question is, now we're really trying to balance like the burden of having multiple devices, the cost of having multiple devices for efficacy. We're trying to make sure that we're doing it for the right reason. Why would we do multiple modalities? Well, they're probably acting synergistically on different circuits. So VNS, we don't know how it works. RNS, we don't know how it works exactly, but we know that they're vastly different circuits that influence epilepsy. And so anecdotally, and based on, again, small case series and case reports, we're seeing jumps of like 30, 40, 50% further seizure reduction. And is that a great number? It's not a great number, but these are patients that really have been stuck at not a great seizure reduction to begin with. So yes, we're improving seizure frequency, seizure control. At what cost remains to be seen. So no report case has ever had an issue with like superinfection or having other burden of having multiple modalities, but that's not something that we've really figured out yet. This is more of an interesting nuance to what we're doing with neuromodulation that'll be borne out probably in the next 5 or 10 years. So to kind of wrap that up, this is kind of the on-label way we look at, I just told you so much about off-label stuff, but this is the on-label way we look at neuromodulation. So VNS, RNS, DBS. So those are your indications for VNS, focal or generalized, RNS up to 2 seizure foci. So again, not for any sort of generalized epilepsy. And typically we're using it in places that are unresectable. eloquent. And DBS, again, can be focal or generalized. There's kind of a cookbook to how you start with programming. VNS is the easiest. You start at a certain set of parameters, you jack it up. And then you put up high enough until they start getting hoarseness, a cough, or voice alterations. And again, when the VNS goes off, it can be painful. And you can see it too. You'll see the patient go like this. There's always the purported risk of cardiac arrhythmias, especially if you put it on the right side. I've never seen it. I have put in right side VNS before without an issue. RNS is probably the more difficult one because you actually have to, again, you as the provider have to figure out the baseline electrographic activity to actually program the device to set it at the threshold it's going to fire. DBS is much like VNS in that you kind of start it low and you go up. Unlike DBS for tremor and for Parkinson's, the anterior nucleus is well out of the way from your ventral caudalis nucleus. Or any type of motor or sensory pathways. So you can get to like 10 volts or 10 milliamps and not really have much in terms of having like contractions or paresthesias. And the side effects, we talked about a bit with VNS. RNS DBS, we worry about infection, but it's not that common. I'm not sure transient memory impairment's a big thing with RNS. It's an interesting thing, but that's on the manufacturer website. And DBS2 memory impairments, that's a bit of a probably a misnomer. The biggest thing though is that all of these are MRI compatible. Any device we implant the body these days kind of has to be, especially for patients that they're going to need a lot of MRIs going forward. There are certain conditions with that, but they are all MRI compatible. And then just the final slide. This was taken from a paper, or I think a paper published a few years ago. I don't necessarily agree with kind of the exact pathway, but it's a good kind of overall overview of how we think about therapy for epilepsy. The one point I always like to make is the only place you see surgery here is once at the very end. So epilepsy, that's focal, that's localized, the one foci, that's non-eloquent, those patients are surgical candidates, good surgical candidates. Obviously, that doesn't include things like disconnections or bigger surgeries. But when you think about it, that's kind of like, that's where surgery lives. Those are the patients that do best with surgery. Everything else here is a neuromodulation modality. A little bit too much on VNS, but again, this is the on-label indications. So when we think about epilepsy outcomes and surgery, I think historically we've placed a lot of weight on surgery, as we should, because those patients, if candidates, are more likely to be curative. But as you can see here, there's a lot more indications for something like a neuromodulation modality. And especially with peds, we're kind of at, like I said, a bit of a breaking point where we've reached critical mass and we're going to start seeing more application, more studies, and then hopefully approval and more implants. So in conclusion, drug-resistant epilepsy is common. We know it's common. When we can't do resection, we can't laser something. Neuromodulation is a reasonable treatment option. We have 3 different modalities. There's nothing else on the horizon right now. We have great evidence for all these modalities. We just need to figure out the evidence for pediatrics, and we need to figure out the evidence for different targets. And then typically when we talk about neuromodulation, it's eloquent cortex, more than 2 seizure onset zones, or generalized epilepsy. And thank you for your time.
Terrific. Have you done any cases here yet?
I've done 1 pediatric central median RNS for a patient from Michigan. And I actually have another DBS for a patient from Michigan who has a VNS coming up.
And the path to get those patients to you, is that all through neurology, epilepsy?
It is through neurology and epilepsy, yeah.
Recognizing that we've got a lot of pediatricians in the room and even more online, for the general pediatricians, what sort of precautions do we need to take with these kids? I'm thinking the RNS in particular. Do they need a helmet for life?
Nope, they do not. Believe it, this thing is very hardy. So the piece of skull we take out, there's actually a ferrule that goes there that is screwed into the skull, which is very stiff, and the battery goes into that. So people, I mean, there's hesitancy to kind of recommend going back to contact sports, but they don't need to live with a helmet. The tissues over top there are enough to protect it. The wires rarely break. I've seen 1 break when someone fell and literally like a point crushed the wire. But the way the leads are shielded, the way they're implanted, they can take a lot of pressure. So that
Obviously, that wasn't what
Punishment.
I was predicting.
Thanks. This was really fascinating. Can you talk a little bit more about this effect where these technologies seem to the effect seems to improve over lifespan? What we think might be happening there? That's quite interesting.
Yeah, I mean, it's a great question. Something I'm not going to have a great answer for you. I mean, we always think that we don't have any plasticity after our brains kind of organized and matured, but we certainly do, and we know that in epilepsy too. If you actually look at tractography studies and fMRIs, the brain changes over time and changes to a number of different influences. And you see that in like adults that are addicted. You see white matter decreases. You see gray matter kind of increase and decrease in response to certain stimulation. So we know that kind of chronic, especially mental illness states change the brain. And so that was kind of the impetus for looking into chronic plasticity for chronic stimulation. So like I said, I don't have a good answer why we think it does or how it does, but we know that the brain changes in response to stimulation over time. And we see that too in Parkinson's as well.
You mentioned the tachycardia activated stimulation. Are there any consequences if the tachycardia is not ictal? Like if they're just
Yes.
exercising or
Good
they're
question.
having arrhythmias? Like does that?
So there's the VNS can be programmed. There's two different settings. One's heartbeat detection threshold, and the other one is I forget the other. There's two different settings for heartbeat detection. So it's a bit of a give and take. You're right. It can be activated when your heart rate goes up too high for other reasons. And so it's more of the but there's a certain cadence of how fast the heart rate rises with seizures as opposed to just exercising basically. And that's what's looking for. It's looking at that certain spike, and that's you can set a detection threshold for that specific denominator.
I understand you introduced neuromodulation in the setting of like medicine refractory epilepsy. Is there any data that talks about after introducing neuromodulation, the change in efficacy of previously introduced drugs? Just because the pathway seems so vague to me.
That's a great question. So the ultimate goal of any epilepsy procedure is seizure freedom. And so let's take a straightforward temporal lobectomy. If someone has temporal epilepsy, you do a temporal lobectomy, there's about a 70% chance of seizure freedom. And that's off medications. So you typically don't touch them for about 6 months. And then you can try slowly weighing them down and see if they can come off their medications. It's a great question because there's not a great answer for it. Anecdotally, we're not seeing patients come off medications. It's an adjunct as opposed to something that's substituting medication. But like we've seen patients with like 4 or 5, 6 medications sometimes, and they can come down on maybe 1 or 2, but they're still being on their baseline medications. So yeah, it's not going to be, unlike kind of the curative resective parts. This is more of an adjunctive treatment.
Thanks. I would have thought vagal stimulation would induce significant bradycardia. No, you must hit efferents as well as afferents, do you?
True, but it's mostly on if you do the right side with the sinoatrial node. That's the worry, and that's why people don't implant on the right. So less so on the left side.
I'll throw one other comment out there. I think what's interesting from the pediatric neurosurgeon's perspective is that we do know that children's brains are incredibly plastic, and their ability through our studies in trauma, both just anecdotally, retrospectively, looking at children who've suffered severe penetrating brain trauma and their ability to regain function that no one ever thought that they would be able to. I think that's what makes this even more exciting. If you look at plasticity studies from adults, seeing how over a 7-year period of time, adults continue to have decreased frequency of seizures and an RNS seizure freedom, the hope would be you would apply the logic that we now know from trauma in pediatric patients, that they potentially have some even more, opportunity to get to higher percentages of seizure freedom because of the child's brain's ability to kind of rewire itself, if you will. So I think that's what's even more exciting about pediatric epilepsy with neuromodulation.
Yeah, I think one of the most profound examples of that is something like hemispheric surgery, especially in like really young infants. You can literally disconnect half the brain, and kids can regain almost all that function. It's pretty remarkable that you can walk, you can talk, you can move your hands. You might have some dexterity issues, but that's disconnecting half the brain, so the plasticity is remarkable.
Well, thanks everyone for coming. Dr. Staudt, thank you.
Thank you.
Have a great day, everyone.